Okay, well, first we will talk about a meter dose inhaler, which we shorten to MDI. Patients will often call this a puffer or inhaler. So what's contained in an MDI is the drug that's being delivered, and this is in a powder form. There's a propellant in the meter dose inhaler that helps suspend the particles within the drug and activate them through the meter dose inhaler. These are a liquid. They used to use CFCs, or chlorofluorocarbons, and for the most part those were damaging to the environment, and they had some adverse effects on some patients because they contained freon. These also were removed because of global warming threats. So what's used now is what we call HFA, or hydrofluoroalkyl propellants. Again, this is a liquid. They're more environmentally friendly, and that's what we use now, and patients don't seem to have many adverse effects from them. There's also a surfactant. Surfactants are used to keep the drug in suspension with the propellant and to lubricate the system. The thing that's so nice about meter dose inhalers is that they're very portable. They're compact and relatively easy to use. They deliver a very uniform particulate, or the dose dispensed comes out within a fraction of a second. So here's the breakdown of what these canisters look like. So again, we have a pressurized canister that's labeled here as this canister. Inside that, you can see, is the drug, the prescribed drug, the propellant, and a surfactant in that liquid mixture. There's an activator, which is a hard plastic case that is specific. The activator is specific to each canister of medications, and the canister again is an aluminum product. There's a metering valve, again, that's specific to the canister that's being placed in the activator, that for every time the medication is depressed, a specific dose is delivered. And then this is the nozzle where the medication is going to come out, and this is where the patient would seal their lips around. When inverted with the nozzle down and it's placed in the actuator, the plastic part that holds the canister, it fills the metering chamber to a controlled amount of drug to be delivered, and then pressing down on the device aligns the valve with the chamber. The propellant vapor pressure forces the dose out of the hole and through the nozzle, and aerosol production takes only 20 milliseconds. Liquid suspension then vaporizes at a high velocity, then quickly slows down. The propellant evaporates, and the particulate size decreases for what the patient's receiving. As nicely as these work, it's important to remember that only 10 to 15% of the drug make it to the patient, and then 80% of the drug in general is deposited in the back of the throat. And that's using proper technique. And so part of our job as respiratory therapists is really understanding the technique and teaching each patient to use this correctly. So the technique for delivery of the meter dose inhaler is to warm and shake the canister. Again, because if the canister's been sitting, the propellant and the drug can fall out of place. So you have to shake that up so you get an even dose. Assemble the device. The technique should be used with an open mouth. hold the meter dose inhaler toward the mouth, and then position the part that goes in the mouth, and it does not go in the mouth, about 4 centimeters from the mouth. It's important to coach them to breathe in slowly, as after they initiate inspiration, then activate the meter dose inhaler, inspire to total lung capacity, so as large a breath as they can take in, but continuing to breathe slow. Hold their breath. It says for up to 10 seconds. Usually 3 to 5 seconds really is plenty. And then wait 1 minute between puffs. The exact amount of drug delivery varies on the patient technique. 2/3 of patients and health professionals do not perform this properly. In general, we instruct the patients to breathe with their mouth open with 2 finger widths away. Some newer MDIs will have a different placement of the device. If the patient can't do this, meaning if they can't open their mouth and hold the meter dose inhaler a little ways away from them, we'll use a spacer. And we'll talk about that on the next few slides. If a lot of the drug ends up in the back of the mouth, and we're delivering an inhaled corticosteroid, the patients can develop an oral yeast infection, otherwise known as thrush. So depending on the type of medication you're using, we'll have the patient rinse their mouth. Again, the only time the patient rinses their mouth is if it's an inhaled corticosteroid or other medications. Make sure to check with these before you're giving them. And then we repeat the instructions. And generally, I repeat the instructions a few at a time in a way that they will be able to improve their technique on the second puff. Successful delivery is dependent on the patient's ability to do 3 things. The first one is to coordinate the activation of the MDI during inspiration. So, can they begin to breathe in slowly and then activate the MDI? Can they create a slow inspiratory gas flow? So if they're breathing really fast and rapid, their delivery will be not as good. And their ability to hold their breath. Okay, there are several different devices that go along with a meter dose inhaler. Some of them are flow trigger devices, whereas the MDI will not activate the delivery of the medication until the right flow rate is received. The other big class of devices are spacers or holding chambers. Spacer technically does not have a valve, and what it does is puts distance between the mouth and the spacer to decrease the particle size. So for those patients that can't hold the MDI chamber 4 centimeters from the mouth, a spacer could be used. Then there's something called holding chambers. What the holding chamber has is it has a valve, and it prevents the clearing of the particles. So it really holds the particles suspended until the patient has the proper breathing technique. The 2 problems we find with patients using an MDI is that they have difficulty with hand coordination and they have difficulty with breath coordination. And if they have either of these 2 problems, more of the drug is deposited in the mouth instead of breathed into the airways where we want the medication. So if we find that they're having problems with the breath coordination, we can get a flow triggering device. And that helps take care of that hand-breath coordination because the device will auto-trigger in response to the patient's inspiratory flow. If you can think about somebody having an acute bronchoconstriction, you can see how if they're having a hard time breathing, it's going to be hard to properly use an MDI device to get the medication that they need. So the goals of the spacer or the holding chamber are to decrease the velocity of the drug. Particles coming out of an MDI are traveling at about 200 miles an hour, so they're coming out very, very fast. If we can get the patient to slow down their breathing, it helps those particles go into the airway. But if the patient can't do that, the holding chamber also helps slow down the particle speed. It also decreases inertial impaction. Inertial impaction is where, as we're breathing in, the particles land. As soon as the particles have to take a turn, which is right at the back of the throat, the larger particles are just going to land on the back of the throat and not be able to make that turn. The spacer also minimizes the oral pharyngeal deposition. It helps improve synchrony with the patient. And like I mentioned, it decreases the particle size. So that smaller particle size is going to be able to flow through the airways to where we need it to go better. Okay, so what about a DPI? DPI stands for dry powder inhaler. These are actually, they are small and compact, similar to a metered dose inhaler. They also contain metered dosing, but they are actually breath activated. So they don't have a propellant that gets them going. The breathing of the patient actually causes them to create an aerosolized particles by drawing air through a fine drug powder. These are a little more inexpensive. They don't need propellants, and they don't require that hand and breath coordination. However, for the use of the DPI, the patient must be able to create turbulent airflow at a specific flow rate of 60 liters a minute. So the patient has to be able to forcefully breathe in at least 60 liters a minute to activate a DPI. So there's many different types of DPIs, and this is what makes them a little bit more tricky. Each manufacturer has come up with its own device to deliver their medication. So in this first picture, it's a roto inhaler to deliver an albuterol. Here's the spinhaler that delivers cromolyn sodium. The turbohaler to deliver budesonide. So these all really vary depending on manufacturer. However, the breathing pattern is the same for all of them. Here is the Advair discus. This discus is probably a little bit more common. Has these doses all kind of rolled up on a little reel. Each one of these little triangles represents a dose of medication, and it's spun around until where it meets up with the patient. Okay, so the technique for the DPI is to assemble the device, however that's done per device, to load the medication in, or to push a button that moves the medication into the spot where it needs to be delivered. We have the patient exhale slowly, not all the way out, but just exhale. Seal their lips around the device and inhale forcefully. I always just say, breathe in as fast and deep as you can, and then they repeat until the dose is complete. Whereas a MDI, generally the order is for 2 puffs, but it's always important to know if you're going to give a DPI how many puffs are ordered. For DPI, usually it's just 1 dose of the medication, but they can breathe in on the device several times in order to get the full dose. The thing that we never have patients do with DPI is to exhale back into the unit. If they exhale back into the unit, their exhaled breath is going to have some moisture in it, and that moisture will cause the drug to clump in the device, and so don't let them exhale into the device. The big things to remember for the DPI is that they require high inspiratory flow, meaning we need to get the patient to be able to breathe in quick and deep at least 60 liters a minute. The other thing to remember then is that the patient should not exhale into the device. Okay, we're going to talk a little bit about a small volume nebulizer. So small volume nebulizers are frequently used in the hospital, in part because they are very easy to have the patient use, and sometimes, under some conditions, more of the drug may get to those patients that can't perform the skills of either an MDI or a DPI. The thing with these is that they take a lot more time. Generally, small volume neb treatment lasts between 8 to 12 minutes. So we'll do a patient assessment, find the type of small volume nebulizer that's used in the hospital, place the drug in the nebulizer. So most of the time we're using unit dose medications that contain the drug and a diluent, but some places will mix these themselves. We set a gas flow rate of around 6 to 8 liters a minute. It's important, however, to know the manufacturer of the particular small volume nebulizer that you're using in the hospital to find the exact gas flow rate that's used. What we find is that if you set a higher gas flow rate, your treatment will be shorter and the particles are going to come out faster, and so they may not get the same quality of delivery as if you ran at the proper flow rate. You'll notice when you hook up a small volume nebulizer, if you set it a flow rate that's too low, no particles are being nebulized, and so you know it doesn't work. What we're going to do is coach the patient to breathe slowly through their mouth. Most of these will try to deliver with a mouthpiece, so they'll seal their lips around the device and just breathe slowly in and out through their mouth. You can use a mask if patients have a difficulty holding that device in their mouth. Small volume nebulizers can also be hooked up to a ventilator circuit. Sometimes you'll see patients tap the sides of the nebulizer, or therapists, because what will happen is you'll have particles condense onto the walls of the small volume nebulizer, and tapping it will bring those particles down. However, in general, it hasn't been documented that that improves treatment if we tap on that, but it does extend the length of the treatment by a little bit. So we continue these aerosolized treatments until no more aerosol is produced, and continue to monitor the patient. There are some breath-activated nebulizers. These are, again, small volume nebulizers that then only deliver the medication during inspiration. So no medication is wasted on exhalation. We're finding we get an increased delivery dose with these type of devices. The valve, and it varies depending on the manufacturer, but the valve is able to sense inspiration. It's a one-way valve, and when inspiratory flow decreases, the patient can exhale and the flow or the nebulization stops. So what we actually spend more time on is selecting what type of aerosol device we're going to use. So the things we have to consider is what's available in the drug formation. Some drugs are only available in DPI. We can't get them in an MDI or small volume nebulizer. Where do we want the drug to be deposited? What is the desired site of deposition? Because the particle size depends on the device we're using. What are the patient's characteristics? So if we have an acute airway obstruction coming into the emergency department, they're wheezing, they're coughing, they're very short of breath, it may be hard for them to use a DPI. We might try a small volume nebulizer or maybe try an MDI, but then see how they do. What we're really talking about is assessment-based therapy. What is the patient's current need, and what are the responses to the treatment? So when we think about peak flow, if we're asking somebody to do a DPI, they have to have the effort or make the effort to take in a quick deep breath. We want to look at their work of breathing. Things that would be signs of increased work of breathing are things like tachypnea, accessory muscle use, if they're restless. And then we want to look at their response to the treatment. Oftentimes, if we're looking for bronchodilation from our therapy, we may do a peak flow monitoring. And we would do peak flow monitoring before and after, so we could see, was the patient able to generate more flow 15 to 30 minutes after the treatment was given? That would say, yes, that they had a positive response. This is working. But we'll also use patient's own perception of the treatment, observations that we have. We'll look at their vital signs before and after, along with breath sounds, blood gas analysis, and oximetry. Take a look at the clinical practice guidelines for selection for delivery of an aerosol device to the upper airway and selection of an aerosol delivery devices. Take a close look at the indications, contraindications, and hazards.